the University of Louisville in the Department of Pediatrics. He's the director of multiple programs at the Bingham Clinic and will be speaking today on psychiatry and integrated care, what we know and what we need to do. Please welcome Dr. Stalker.
Thank you much. Unsupported signal. Check your device out. I very much appreciate your having me here today. I'm talking about something that's dear to my heart, and hopefully make it clear about why shortly. You've had a lot of good, hard information from the first speakers. This may be more soft, but it's also something I think that's more important as far as developing your clinics and what you're going to be dealing with in the future. We know that the outcomes in primary care are going to be quantified and financially rewarded or penalized. And at the same time, you are undertrained and unable to bill for the time to take care of many of the problems that present in your practices. Is this right? Does anybody here have a social worker, psychologist, or a psychiatrist in your practice? Well, Faye, you don't count. All right. Also, if you have arrangements for mental health services, you have to refer out, but many times unavailable, or you might say not as good as I think my patients deserve. All right. So we're talking about something that sounds like the medical home, but I always, from my day, look at it as holistic medicine, because we know that to treat a child and family, you have to not care just of the body and then dish off mental health issues to the psychologist. You're looking at the impact of culture, environment, community on the functioning and health of the family, which is essential for the health of your child. And you all are the front people. The idea of a medical home would be you have one-stop shopping. You are more likely, I believe, to get better care and identify problems earlier on. But how do you build that into your practice financially and practically? All right. The usual suspects. I'm going to go into 3 different forms of integration of mental health care into the pediatric practice. Nothing is hardly black and white. There are a lot of variation. But the first is coordinated care, which is probably what most of you all try to do. You may have a semi-formal or even a formal relationship with mental health providers in your community. There's no direct access of information that's being shared because you don't have a shared EMR. And then we've also got the firewalls of psychiatry and psychology of can't release that information without an act of God. And by the way, you'll never get a report from us. Thanks for your referral. With this relationship, there are no financial ties or remuneration. The quality of the service depends absolutely on the quality of that local mental health provider. And that's been your experiences, yes? Okay. They're not usually physically situated in the practice site. They may be fairly close physically, but it's still a moat, and it may take weeks or months to get a referral. Does this sound fairly accurate to your experiences in your practices? When you know you want it, you know you'll never get it. Mental health referral. The other thing that happens with this kind of referral model is that you tend to speak 2 different languages and maybe not understand why are they doing that, or that's not the reason I sent them there. And then, believe me, many of the mental health providers really don't understand your philosophies, your models, your paradigms, your algorithms, and truly different languages. And since they're separate practices, you don't have the chance to sit and talk curbside, understand each other, primarily because there's the distance and mode effect, and you also don't have the time. The agenda for most pediatricians that have referred to the Bingham Clinic and other mental health providers is help my patient financially now, as well as practically, help keep my patient out of the emergency room because WellCare and Passport are going to penalize me when my kids are in the emergency room. Thank you, capitation. The last is really, please take over my hot mess. And many times folks in their frustrations and exhaustion conceptualize problem families, complex families, as just that, a problem. This is the black hole of a referral to child psychiatry. You've made your report, it's been sucked up, you'll never see it again. The next thing to come along is what we call the co-location model. And you're going to find that I'm leaving a lot of time. Again, my data is not statistical, most part. So I do want you to feel free to ask questions about anything that we talk about today. This is where, in a co-location model, the mental health practitioners are present in the clinic physically. They're an informal part of the practice, not formal. There's still a separate EMR, usually. In our model it is, here at the University of Louisville. And there's still firewall barriers to data transmission. It's tend to be one-way firewall, unfortunately. You guys send us lots of information. We have to dig to find what we need. You can bill separately as allowed by law. Now, if you have something like Anthem or Humana, you cannot see an MD physician in psychiatry at least, and also a mental health provider like a psychologist and bill in the same day. Extremely inefficient. It's uneconomical. People have to make 2 trips and 2 copays. But for Medicaid, you can do that. So there are no worries with this population. Usually a release of information has to be obtained to be able to talk about these patients. So you're in the clinic, all right, to really talk about the patient in general, they need to have a signed release that says, yes, you can talk to Dr. Wazinski or whomever in your clinic about your mental health issues. Not that practical, but it's better than referral to community. And is this what some of you have started? Physicians to Kentucky and Bardstown, is anyone here? Those guys are busy. We actually had that model a few years back where the Bingham, myself, and one of our fellows went to the practice, and we were there 1 day a week. It was co-location, separate, but it was still wonderful in many ways because we were able to communicate and curbside about what we were trying to help them with. Answer their questions about Risperdal. How many of you have had to write for an atypical antipsychotic in the last week? Raise your hands, please. In the last month? Absolutely refused to do it no matter what? Okay. And yet many times you're asked to. And that's a different part of this talk. Now it's a parallel service co-location. Usually somebody will provide therapy and somebody may write for psychotropics. Could be the same person. All right. There's separate administrative staff. So in our case, we would set up in a clinic. It would still be like a Bingham South. They'd be registered through our clinic. It's just the physical site was different, but we didn't share the EMR. Our scheduling people had to do it. Our billing people had to do it, which meant we had to pay for those services. All right. Not onerous, but that's what we had to do. So you take a coordinated care where you're referring out to the community to actually the same model, but it's in your clinic. So the benefits are you can see those people. If you have a crisis, if you can work out the arrangement or a procedure, you can say, hey, we've got this kid in 12, what to do. The flip side that was good for me is that I might pick up on some acute illness or other medical problems. Then I can get right to the pediatrician and say, hey, I was seeing your patient, found this, mom said he's having drenching night sweats, orthostasis, and he's allergic to cefdinid. Curbside education and learning the same language is a really neat thing. It's an important thing to be able to do with co-location. You at least have the opportunity if you don't have the time. Now, it gets to what I think we need to go to, which is the integrated model. And again, I'm old enough to remember holistic medicine and the failures thereof, and the fact that many pediatric practices were very comfortable with psychology and social work, but it was like a different universe with child psychiatry. Okay, well, those days have changed and gladly have gone. But what would happen is that in the clinic itself, whether it's an employment or however you end up having to do it, you would have trained mental health professionals that would be able to look at your screening process for early signs of family dysfunction. And we already do that to a large degree, but also mental health functioning. All right. They would be part of a comprehensive treatment team. What's nice about this in the long run is that it could destigmatize mental health problems that you all see in your practices. In Kentucky, we have more than 1 million children under the age of 18. And you've heard about some horrible illnesses already, childhood cancers. But if you look at the statistics, anywhere from 200 to 250,000 children in this state alone have a diagnosable and treatable mental illness. And they're in your practices, and they're presenting. And they may not present overtly symptomatic, but they're there. And they affect how well your treatments work for other illnesses, compliance. These kids can be under chronic stress, which means their immune system is dysfunctional. All right? They're pouring out cortisol. They've got DHA. They've got dysregulations. You name it, these kids are sick. Their families are sick, and they're getting worse in Kentucky. They're throughout the country thanks to our addiction problems. But the nice thing is that the integration model destigmatizes all of that and accepts this as the reality of what your family and your children are dealing with and what you are dealing with and what you're asked to deal with. The pediatricians are still the team leaders. Okay. But it brings mental health into the forefront of patient care. And again, I'll go back to those numbers. 200 to 250,000 children in this state, moderate to severe mental illness. We'll go lowball and say 200,000. For most people here, how many people feel that 20% of their practice has to do with mental health care, or at least is impacted by mental health problems? 30%. 40%. My sympathy. 50%? Yeah, we know it. We see it through poverty, lack of follow-through, you name it. So, integrated care. The reason I'm so excited about this is that there will never be enough child psychiatrists and really well-trained child psychologists to meet the needs of our children. All right? You all will be the ones to identify the need, initiate treatments as best you can, and do follow-up outcomes. And remember, going back to the earlier slides, there will be financial reward and penalty, right, for keeping your kids out of the emergency rooms and hopefully keeping them off of expensive medications like whatever the new antipsychotic is of the month. Fair enough? It will allow for better research for outcomes. Right now, again, the moat system and the academic silos doesn't really allow us to communicate quickly and effectively. And even with my pediatric colleagues at the University of Louisville, many times we do talk a different language. They're great, though. I will shout out Amber Pendleton, Jennifer Stiff, especially, as advocates for integration at UOP. One thing I would like to say, why was it a child psychiatrist who's been so comfortable in our office seeing 4 or 5 kids a day want to go into a pediatric practice where many times it's like the Louisville Zoo? It's in that way in our ADHD clinic too, but that's a different story. It's Willie Sutton's law. Does anyone here know Willie Sutton and what the law is? Willie Sutton was a bank robber. And they asked him, why do you rob banks? And he said, well, that's where the money is. So if you want to do mental health care to help our communities, you go where the kids are. A vault. That's actually kind of cute. So the idea of putting mental health professionals into your practices as part of your practice is to go where the pathology is. For the folks that said 50% of your outpatient care may have mental health related issues or needs mental health related issue treatment, put the people there. If you send them to Bingham, I can tell you that we have limitations. Every clinic, every provider does, about how quickly we can see them and how many we can take. Okay. Now, as part of the idea of a team, a holistic team, to include mental health and all the impact of ACEs and genetics and epigenetics, et cetera, I think that the quality of the relationship is analogous to the placebo effect of medication. You can be a great doctor and a lousy clinician if you don't have a warmth, understanding, accepting, tolerant perspective in working with your families, especially the families that drive you bug nuts because they are so difficult, demanding to work with. And yet the quality of all the care you give, whether it's otitis media care or referral to a specialist, will depend on your relationship. By incorporating integrated mental health into your practice, you're kind of saying, we believe in all of you. Not just the happy parts, and we'll take care of your kid, and their ear stops hurting, and then everybody's happy, and we've done our job. Except for the 40% of you that are difficult to work with. Now, the other thing that integration will allow you to have is a crisis plan. What if you have the difficult parent or situation in your office and you can't deal with it, and they're not going to leave? And you're thinking, well, do I call the police? Do I call CPS? What do I do? But it would allow someone in your practice, already identified, to do an intervention where you don't have to do it. And many of you would probably go, hallelujah. That sounds really good. It's not that easy, but it's part of what we do. I would say this, when you have a difficult situation and you think it's mental health related, which is a phrase that really is a barrier phrase when you think about it, it's health related. You could confront, fire the family, call CPS, and you say, well, I've done my job. And quite honestly, that's an easy thing to do, and it's really not, I think, the best thing to do. There will be times that you will need to call CPS, but if your system itself tries to defuse a crisis, work with the family into the underlying reasons why things are so problematic, why there are such hot messes, then you may be able to help that family, help that child, and not necessarily have to just pass them on. I think a lot of pediatricians I've talked with over the years do get tired and just say, fine, we'll fire them. Go somewhere else. And then you've got a child in the community who's going to grow up underserved, mentally ill, behaviorally ill, functionally ill, and then you've got Kentucky at 45th in the nation for health issues. We're up, apparently, from 48th, because 2 years ago we did the ACA, which is going away. True quotes, and if you all recognize these, just raise your hand. I'm not going to write for these blankety-blank meds. I don't have the staff, and I don't have time to do Caspers. One thing that's frustrating me is that at the Bingham Clinic, I used to do screening for all the referrals for care, and I was getting pediatric referrals to diagnose and initiate ADHD treatment. It's like, no, this is a tertiary level clinic. You guys have to do this. But a lot of pediatricians in this state are not going to do ADHD treatment anymore. I don't understand why. And perhaps that could be after this talk. But part of it was Caspers. It costs too much money. I've got to see them more frequently. I have to see them more than capitation allows. I lose money on these kids. If I do it, I lose money. If I don't, I lose my shirt. These families drive me blanking crazy, and then how can you do this every day? So that's some perspective, and I think it's really based on frustration and the inability to do the job that's probably in your heart to begin with. Pediatricians are a special group. Underpaid, overworked, and you do it initially at least because you care about kids and families. Hopefully you can continue. All right, now, here's the flip side. Me to a U of L pediatrician, hey, and you know who you are, you're here. Would you mind writing these meds for this kid? He's stable and he's doing really well. And there's the bag of like 7 different medications. Now he's stable. All right. And this may be how you feel at times when you're asked to take over the psychiatric prescribing on these kids, but many of you will get kids coming out of a psych hospital who have been started on pie-in-the-sky medicines that the insurance companies are going to deny after 7 days, or you're going to have an anticonvulsant, a stimulant, an alpha-2 agonist, an atypical antipsychotic, and the kid's stable, and you're supposed to write for it. Some of you will say, I'm not doing it. Some of you will say, oh, I'll do it, but I'm extremely uncomfortable. And I've heard understandable rationalizations for both. So how many of you have had to write complex psychotropic medications for kids coming out of the hospital? All right. How many of you are comfortable doing that most of the time? All right, but you do it. Avery? Yeah. What about the medicines? Again, we have a deficit of around 30 to 40,000 child psychiatrists in this country. Nurses, the CMHCs cannot hire child and adolescent psychiatrists. There's not enough of us, and they don't compete financially. And they're expected to see patients every 15 minutes to write for complex medications. And we have a very good understanding of the psychosocial determinants of mental illness, and we're not allowed to touch that. So even within the CMHCs, like 7 counties, which is now Centerstone, Adonta, Communicare, can't get good and competent docs and keep them. A lot of them get out because there are financial opportunities now with telemedicine for a child psychiatrist to stay home, put on a shirt and tie and their bunny slippers and their jammies below the waist. They're on a TV all day and they're making twice as much money as they can make at the university. Now you can say, well, they're serving some kids, but they're not serving the kids that are in your practice and the ones that probably need it the most, the kids that are on Medicaid, right? Nurse practitioners can help, but it's the same story. There's not enough of them. Many of them are competent. They should be in competency somewhere between a good pediatrician and me. They should know more about psychotropics and interactions than you all do. If they haven't learned that and you're actually more competent than them, you don't need them. But that says a lot about you and your abilities. Integrated care. The thing to do to make integrated care work is find somebody in your practice that will champion integrated care. And it probably needs to be somebody at the MD level, but they have to be motivated. They have to be willing to coordinate initially how the services are going to be provided, who does what, working out with you all, if it's not one of you. Who does this? Who makes up our policies and procedures? Okay. In the very beginning, mental health is presented to these families, hopefully in pregnant young mothers, as part of our treatment team. Not distinguished as mental health. Oh, this is Dr. So-and-so, this is nurse so-and-so, this is Dr. So-and-so. We take care of you and your child. So the idea is shifting away from the silos of pediatricians only, dealing what you have to deal with, to integrated care, and on the other end, getting us out of our silos. We destigmatize mental illness, okay? And so many folks still have, it's a moral failure, pull yourself up by your own bootstraps, it's genetic, there's nothing you can do about it. All of this isn't accurate. This is a presentation of an integrated team. This is Dr. Sockmonkey, if you can see that from psychiatry. If you also notice, there's 4 providers plus Dr. Sockmonkey there, and this poor child is being overwhelmed. This is not the way to do it. I wrote down, this is exposure therapy for a child with social anxiety. Exposure therapy is where you force them to experience what terrifies them in the hopes that they won't have a heart attack, an acute MI, a vasovagal event, or something else, and that it'll cure them. Well, a little bit of humor, maybe. The warm handoff is how things can also get going. Have you all heard of the warm handoff before? Okay, we're almost. Warm handoff says essentially that the treatment team will introduce the mental health provider to help the child by, say, the primary care pediatrician will take the person and, hey, this is Dr. So-and-so, she's with us, she's going to help you more with this problem. Warm handoff is critical, and I can tell you that the managed care companies really emphasize the idea of the warm handoff, not just that they don't, you're in the practice, they want to see the pediatrician, the primary nurse, the mental health practitioner together to emphasize again, hey, it's part of the team. I'll read this quote out. Mental health care seems scary or embarrassing. This is going to be something that you're saying to your family. But in our practice, we know it's only part of the spectrum of health concerns that all people have at one time or another, that we will treat your issues directly and with respect. With what we know about stress, health, and illness, we must address these issues or we're not doing our job for you. And I think most people here would agree with that. But you can't. Not by yourself. Jack did not get a warm handoff. Now, I emphasize again why this is so important. We are learning a lot about ACEs, the impact of chronic stress, toxins in the environment, community stresses, and the physiological damage done. Epigenetic modification of your genes. You can be born with great genes, have a crappy childhood, and epigenetic modification of your genes may make you more sensitive to illness, immune dysfunction, hypertension, metabolic disorders, etc. So it's critical that we take this information and use it as a basis of smart clinic development. Again, I had to throw an ACEs chart in there. Is there anyone here that's not comfortable or familiar with ACEs? All right, ACEs is the tip of the iceberg. We're learning a lot more about what specifically we need to do to help. All right, how do you do it? Well, if your practice is large enough, and I'd say about 4 to 5 PCPs, primary care physicians, you might be able to start with a psychologist or an MSW with experience and training and interest in integration. Reimbursement is doable. Okay. Will you make money on it? Probably not. Unless you can put a dollar value on your own mental health that improves because you're taking care of these problems and you're not having to. And some people will look at it that way. Boy, this is, I may not save me any money, but it's given me 10 extra years of my lifespan, and I'm probably less likely to have Alzheimer's or stroke out, which I've heard before. What we do at U of L, and I'll be finishing up very quickly, is that we are started the co-location model, hopefully moving towards integration at 2 of our pediatric clinics. We have a fellow there 1 day a week in Stone Street Clinic and a different fellow 1 day a week at what used to be Children and Youths, and I go down on Tuesdays to do different clinics. So it's co-location, but with a lot of opportunity for teaching and curbsiding, which I find essential. All right, I'm going to go through this quickly because we're just about out of time. On the website, Integrated Care for Kids, the American Academy of Child and Adolescent Psychiatry has essentially logged all of the different programs throughout the country trying to develop and foster integration. And we have our own little spot at this website, but you can find information on advocacy, program development, the library, and this is on your slide kit. So please look at it. The most famous and probably the most notorious is the Massachusetts model, where the state itself, with some initial funding from managed care organizations, paid for telephone access full-time for a child psychiatrist, a child psychologist, and a social worker to answer questions. We're already doing that on the free for our group, but we have a long ways to go. Links that I gave for you, again, these are all very good. If you have any interest at all And exploring the finances of doing this in your practice would probably take your business manager, your partners, and then even approaching your mental health MCOs about what can you do to help us here. They do want to cut costs, they want to keep kids out of the ED, and they want to stop spending money on atypicals, especially. And with that, I'll finish. Any brief questions? Yes, sir.
In the light of the recent shooting in Kentucky and Florida, my question is really, you as a healthcare professional, psychiatrist, you can probably predict when a person is going to snap.
Yes.
But let's say the relatives, how can they probably predict if the child is going to snap?
Ooh, such a complicated question because it gets into the courts of law and what the rights are of children versus adults at 18, how jurisprudence works in this country. Because how can you mandate treatment for someone that refuses? Kentucky is trying to do that for the most severe, chronically mentally ill adult recidivists, and even then, it's very difficult. So if you have some, we've identified in my practices over the years and talked with people, we know a child is going to kill somebody at some point. We treat, we warn, but can we intervene to prevent it? Not without legal support.
I tell you, a lot of people say that it's not due to the guns, okay? I grew up in a country where guns are illegal. So we never saw this shooting. We have a lot of stabbings, knifings, because guns are illegal, okay? And I think that must be the problem with our country, because guns are all over the place. And now if we cannot tell when a person is going to stop, then we're going to have a problem.
And again, you get into cultural, legal, what it is to be an American, where we have 80 guns for every 100 people. In Japan, with gun limitations, they don't have gun shootings. Even Canada has a lot of guns, but they don't have shootings. Not to the degree that we do, but stabbings, oh, you bet. But the question is, it's accessibility in a developing, mentally ill, immature mind with a very vague and ambiguous message from our cultures about it's okay to have guns. People trying to stop your guns are violating your rights, they're the enemy. Things happen in a child and a teenager's minds that plant seeds, and what they experience, what they're exposed to is what they'll believe. It takes a long time to get a discerning, rational brain, or mind if you would, to stop and weigh things out and say, you know, I may be wrong on this. Or I wish they hadn't told me that. Or I wish I hadn't grown up there. It's a whole different story. Thank you very much.
Thank you, Dr. Starker. So right now we'll have